Welcome everybody to this webinar Wednesday. Welcome to Dental XP. This is Dr. Andrea Agnini speaking, and here we have also Alessandro.
Good webinar Wednesday also from myself, and thanks to all the Dental XP team for the video editing and to the Salama brothers for having us here once again.
Today we will be speaking about the surgical veneer grafting protocol, which is a protocol that can be utilized in immediate implant placement, and this is going to be also the topic of the hands-on that we will be doing in the Dental XP Global Symposium next February in Miami. Before to start, you have the opportunity to enter and join our reserved area in our website, which is www.studioagnini.it. You basically have the opportunity by simply filling your name, last name and email to receive a link in where you can use this password Dental XP, and for all the next week you will be able to enter and download for free articles, insights of our book Digital Dental Revolution edited by Quintessence, and especially the articles on the surgical veneer grafting.
So let's start now. Today's goal is to explain you the thought process which brings us to develop the surgical veneers grafting protocol.
And as I was mentioning before, this article was recently published in the Journal of Cosmetic Dentistry in the winter edition, together with Team Atlanta, which helped us a lot in created and define this protocol.
Okay, in anterior maxilla, the aesthetic outcome and its long-term aesthetic stability is of paramount importance. That is why we should consider all the options we have and what we should do before extracting the tooth.
And options are different. First of all, we have timing option, and this is one of the most important and most famous consensus conference which everybody refers of, such as the timing, because it depends compare when we extract the tooth, when are we going to place the implant. We have type 1, type 2, type 3 and type 4. Type 1 is the immediate implant placement, so we extract the tooth and we immediately place the implant, and we have the type 2, which is what has been called the early delayed implant placement, 4 to 8 weeks after the extraction, which is the Boozer and Belzer favorite approach. And then we have type 3 and type 4, 8 to 16 and 16 to 20 weeks later. But timing is not the only option. Depends also which kind of scenario, which kind of anatomical scenario we are in front in order to decide whether to place or not to place an implant. And these two articles, one from Team Atlanta and one from Dennis Tarno, are referring to the type 1, type 2 and type 3 socket classification, which is basically the presence or the absence of the buccal plate. Type 1, we both have buccal plate and soft tissue, whether in type 2 we have soft tissue but we are missing the buccal plate, and we will see that in this specific clinical scenario it is going to be very critical to do a defined and strategic diagnostic approach, while in type 3 we are missing both the buccal plate, the soft tissue, and we have loss also of interdental bone height.
So, the type 1 scenario could be defined as the ideal one, with the presence of the buccal plate and the soft tissue as well. But is it always so ideal?
Well, ideal situation means that we have 1 millimeter of thickness of buccal plate and a thick gingival biotype, and unfortunately this ideal situation is not so common, and we will see that the literature is telling us that mainly roughly 15 to 20% is this ideal situation. So we should think also what should we do when we have a buccal plate which is thin and a gingival biotype which is thin. Of course, we also need to think that how can we diagnose type 1, type 2 and type 3 first of, and how should we approach, because the main goal in type 1 scenario is that we should preserve, we should maintain what Mother Nature gave us, and so we will see all the possible procedures to obtain this goal. When we are in a type 2 and a type 3 scenario, so we have a tooth present but without an intact socket, all our effort should be directed to the restoration of an adequate alveolar and gingival height before placing the implant. So you see that Type 1, type 2 and type 3 have very different ways of being treated, and today we will focus in mainly on type 1 clinical scenarios.
The possibility to choose immediate implant placement with immediate provisionalization provides several benefits, such as a reduced number of surgical procedures and consequently a decreased treatment time, Andrea. Avoiding interim removable prosthesis, increased patient comfort, but most important, a better soft tissue contour preservation.
And so basically our goal should be to create an harmony in tissue profile and color, and all the variables, all the parameters which are involved in this are basically the hard tissue, which is the bone, the soft tissue, which is connective tissue mainly, and we will discuss about the importance of managing properly and utilizing the connective tissue, and also the restoration. So we will discussing about the prosthetic contour, the choice of the abutment, and which kind of material do we have today available.
So we should define the two possible clinical scenarios: immediate loading implant in a fresh extraction socket and immediate loading implant in a healed ridge. Those are two completely different ball games.
Yes, actually they are two completely different ball games, because even if we are discussing about immediate loading implant, it's much easier in a fresh extraction, so it's more complicated in a fresh extraction socket to obtain primary stability, which is the key parameter to achieve in order to immediately load the implant. Whether we will see that it's going to be easier, as Alessandro already mentioned, to preserve, to manage the soft tissue around. On the contrary, when we are placing an implant in inlet bridge, due to the fact that we have the bone crest, which is already there, as you can see here in the video, obtaining primary stability is easier because we don't have that empty canvas, we don't have that empty socket like we have in the immediate implant in a fresh extraction socket. But we will see that the soft tissue management requires a different skill. So let's see this case that was treated and completed by Alessandro 10 or 12 years ago with PFM full mouth restoration, that down the road had this complication. You see that we have this bridge 14, 15 and 16. Unfortunately we had a fracture, a palatal fracture on number 14, and the patient is walked in to the clinic asking what could have possibly done, and of course she didn't want to have an hole in her mouth. And so we should think not only how can we treat that specific scenario, but how can we strategically sequence the different corrective therapies. Here you see that we have we have two different scenarios here. We have probably one a fresh extraction socket to treat, number 14, and we have one elet ridge or number 15. So in order to avoid an interim removable prosthesis to this patient, we can place two implants, one in a fresh extraction socket, one in an inlet bridge, which, as I just mentioned, are really two completely different animals to treat, but at the same time we should manage properly the provisional restoration. We should define also the clinical scenario we are in, and it's a type 1, and actually it's a type 1 in number 14, which is an ideal situation because we have a thick buccal plate, we have a thick gingival biotype, and we are mainly in the posterior region. So let's see how this was treated. You see extraction the same day, and in the same day was placed an implant in a fresh extraction socket and a flapless implant in the elet region number 15. Of course, provisional restoration was the key in order to maintain that soft tissue around those implants.
In fact, thanks to the properly shaped provisional restoration, it has been possible to manage at best the soft tissue around.
And we will see that managing the soft tissue, it's really the key, because the soft tissue are basically the frames of our final painting, which is our restoration.
Look, in fact, the situation at 3 months follow-up. Once unscrewed the provisional restoration for the first time,
and here we have two implants next to each other, and look at the inter-implant papilla. We were able, thanks to the proper implant, to the correct implant placement and to the proper provisional restoration management, to preserve this soft tissue all around the implants, and in this way maintaining the overall aesthetic of the restoration.
and being in the posterior area and in maximum intercuspation restoration, there is the chance to combine the digital impression benefits together with the monolithic materials ones. Two adjacent implants splinted together, passing from the impression appointment to the final restoration in one single shot, avoiding also to produce a model. But let's now take in consideration this case, apparently similar to the previous one, with one post-extraction site and one healed ridge to manage in the lateral incisors area.
Yes, only apparently similar to the previous one, because here, first of all, we are in the anterior aesthetic area. We have thin gingival biotype. In the previous case, our goal was mainly to maintain the inter-implant papilla, while here, our goal is to maintain the overall volume buccopalatally.
Yes, buccal palatal collapse of the ridge is a significant challenge in the restorative and implant dentistry. And this is why you will always see the occlusal picture of each case we are presenting here today.
And look, for example, at the aesthetic risk profile of this young lady.
Yes, it was extremely high as shown by the exposure of the transition zone. The spaces were regular but also narrow. There was no interdental bone loss as shown by the periapical X-ray evaluation.
And look, in these kind of cases, the diagnostic approach is critical, the anatomical scenario.
Yes, the gingival biotype and the interdental attachment bone level are mandatory to collect before deciding which corrective therapy to utilize and its strategic sequence.
Diagnostic approach, clinically speaking, is of extremely important, but is not the only one that we need to detect, because also the anatomical structures, thanks especially to the CBCT evaluation, are of crucial importance in these kind of cases. We need to record all the information of the bone volume, of the mediodistal size, of the height of the alveolar bone, and all of these information are given by the CBCT analysis, which we strongly recommend to do in each specific case when you approach an anterior aesthetic area. And this is how we treated this specific patient. In tooth number 2.2, we placed an immediate implant in an inlet ridge, doing also a guided bone regeneration in order to recreate the root profile of the situation. And you see that we also add like a surgical guide, because we strongly believe that the implant must always be prosthetically guided, and this is what we did exactly on the contralateral side as well, because it was a reduced, if we can call it like this, since we have a baby tooth on number 1.2, reduce fresh extraction socket, where we place our implant, also in this case prosthetically guided. And this is the final situation at the end of the surgical protocol of this specific patient. But when we discuss about immediate implant in the aesthetic zone, we will see that we will always need a protocol which is a combination of a surgical procedure and a prosthetic procedures.
And despite we have two different anatomical sites, the prosthetic management does not change, protecting the surgical site with a rubber dam and relining the provisional restoration shell directly in the patient mouth in this case. Shaping properly the emergence profile of the provisional restoration is a key, but also smoothing and steam cleaning it will help the provisional itself to mechanically support the soft tissue.
And here we have the same occlusal picture at the end of the prosthetic procedure as well, and you can see that the two sides which as I said are different, they look also different, because on one side it was also done a guided bone regeneration to recreate this root profile, and the soft tissue was splitted buccally in order to give this anatomy, while on number 12 or number 7 nothing was done, only placing the implant without opening any flap, and then on top of it placing the provisional restoration.
The provisional restorations in place. This image will explain the two different scenarios. As a clinicians, we must know how to properly shape the provisional restoration, communicate with the patient that we have to wait biology to do its job without panicking. Look at the follow-ups at 2 and 4 and 5 months. The soft tissue is healing properly, Andrea, thanks to the presence of the contact points and the proper design of the emergence profile of the provisional restorations.
And this is a 6 months picture. You see the two different scenarios that are looking alike, they're looking the same, and this is what our patients wants to see, because for them they are only two implants with two provisional restoration on top. So we should always think biologically, the importance of the communication with our patient, the importance of knowing how to properly shape and how to differently manage these two anatomical scenarios. And at this point we can move forward with the final restoration procedure.
At this stage, we had the opportunity to incorporate new working tools, such as intraoral scanning technology inside the treatment plan sequence.
And here you see the digital impression that we are taking in this specific case with the true definition scanner. We have the scan bodies in position, which are basically our digital impression copyings to detect the exact position of the implant in our patient's mouth.
Yes, and from the occlusal view, you can appreciate the root profile, the soft tissue thickness, which are exactly duplicated in an STL file.
But we also know that we spend a lot of time to try to maintain that buccopalatal volume, and as soon as we unscrew the provisional restoration, the gingival tissue tend to collapse. But digital technology gives also the opportunity to bypass or overcome these slight problems by simply taking the impression of the digital impression of the provisional restoration emergence profile, because acrylic or PMMA does not shrink if you compare it with the gingival, with the gingival tissue. And here we have one way of detecting the emergence profile that was firstly described at the last year Boston Quintessence Symposium together with Maurice Salama as well, which we call simplified digital impression. Here we have the different files that were detected in the patient's mouth, and in the upper right picture you see that the two provisional restoration which has been detected outside of the mouth, which are incorporated then in the CAD software, and we are finalizing the case with all the variables under the control of our dental technician.
The scan body best fit at the top of the screen, and the double check of the implant axis in the CAD screen.
And after that these data are elaborated, we can send them to production. And what can we produce? Since we are in an aesthetic area with a high aesthetic risk profile, we want to produce maybe 2 PMMA prototype in order to see if we need or if we not need to do any adjustment, especially in the provisional, in the emergence profile point of view. You can see here that this patient has also a macrogingival issue on number 13, 14 and 15, that this was addressed at the consultation, but the patient, due to economic issue, didn't want to proceed with that. And this is also the reason why we didn't do any connective tissue augmentation at the moment of the implant placement on number 12, on number yes, on number 12 or number 7 with the American classification, because we want to keep it narrow down the road when this patient, since he's young, is going to go through the mucogingival surgery, to add connective tissue at the moment of that specific surgery.
Here you can see the digital model was then produced after the data elaboration at the CAD software by the lab technician.
In this case, if we compare it with the previous one in where we didn't utilize the model is important because the dental technician needs a position to layer the ceramic on top of this zirconia framework to optimize the overall aesthetic of the case. But the overall aesthetic of the case is probably optimized by this pink tooth, by these pink frames, because we will see that the pink is always optimizing the white tooth form created by our dental technicians. And here we have the before and after of this patient, and you can see how we can change and how the smile was improved by the managing of the two lateral incisor, and how challenging was this case aesthetically speaking.
Yes, the primary objective of implant therapy in the aesthetic zone is an optimal aesthetic treatment outcome with a high predictability and a low risk of complication. However, those outcomes must be reviewed from a mid to long-term perspective, since the stability of the facial, hard and soft tissues is most important. One of the key to achieve then, at the end of the treatment, is a correct balance between the white and the pink aesthetic.
Yes, because since we are discussing about aesthetic implant dentistry, we will see that everything is about the pink, which gives us the opportunity to optimize the white tooth form. But let's take a look, for example, at these two according to the Albertson criteria survivor implant. Do we have a perfect balance between the white and the pink here? We don't really believe so. You see that basically these are more complications. Those are ugly teeth, and ugly is a disease for our patient. But we need to carefully read the literature, because most of the time literature is focusing only on implant survival rates, whether the aesthetic parameters are most of the time underexposed in most clinical trials, and there is a lack of objective or uniform criteria for implant aesthetics.
We should then know how to strategically sequence the therapies in our treatment plans to avoid this kind of complications, implant malpositions, abrasion and recessions, but also to manage them properly. To solve this, it has been first removed the existing implant crown, reduced and re-prep palatally the implant abutment to recreate a space, and we applied a new provisional crown, starting to conditioning the soft tissue. To optimize the final result, it is a must to thicken the soft tissue. 1 month after, it has been performed a bilaminar technique consisting of a coronally advanced flap covering a 2 millimeter thick of dense and white connective tissue graft.
And also, especially, how do you manage the connective tissue graft is critical, because literature is telling us that if it is properly harvested and properly managed, connective tissue remains stable after the restoration and has clinically insignificant tissue volume loss. And this is extremely important. You can see here in this picture how the connective tissue graft is basically adapted on top of the root, on top of this fake root, if you call it like this, but also on top of the provisional restoration, also giving stability to the flap above.
Notice, besides the quality of the soft tissue, the re-established gingival symmetry, recreated also by treating the adjacent teeth recession and abrasions.
Yes, because you see that we didn't only focus on the complication on the implants, but we were addressing also the macrogingival problem on number 14, which is also a tilted tooth, and so recreating with the filling the CEJ and then managing, thanks to the connective tissue graft, that macrogingival problem, we were able to recreate the pink frames in order to finalize this case. And at this point we can finalize the case introducing new working tools such we did in the previous cases, such as the intraoral scanning.
Yes, with the new digital tools is now possible to copy and paste the provisional restoration, including the restoration emergence profile, which will support the gingival tissue.
So basically the same concept that you saw in the previous case, but in this moment done in a titanium abutment post. Here you see how the details can be copied in a digital way, and especially the details that are the most interesting in our point of view in this kind of restoration, which is the emergence profile, which is supporting the soft tissue. Of course, we need to have a scanner which read in depth in the sulcus in order to give this information, this valuable information to our dental technician, in order to exactly copy and paste the emergence profile of the provisional restoration, which was already tested in the patient's mouth, and duplicating exactly in the exact same way for the final restoration, without any model, because in this case we decided to go with a monolithic zirconia rehabilitation.
And here, the before and after. In conclusion, the emergence profile of the replaced tooth will perfectly mimicking into the adjacent natural dentition.
Of course, it was necessary a multidisciplinary treatment plan, a multidisciplinary approach. We needed to address the macrogingival problem, we needed to manage properly the provisional restoration, so pros knowledge, but also we decided to go for a monolithic zirconia, and we should also know how to treat the different surfaces in order to increase the bonding, in order to increase the adhesion to obtain a long-lasting restoration. So the cementation protocol that here you see in a scheme is of extreme importance, is another details of the whole project for the final successful outcome.
So this case demonstrates the possibility of fully correcting the peri-implant soft tissue defects and achieving high patient satisfaction.
And I think that this case also showed us also the importance of the connective tissue in our clinical armamentarium, because without the connective tissue we would have not been able to solve this case. But the question is, yes, we had a complication and we will able to solve it, but how can we avoid this kind of complication, which are very difficult to treat? We should always think the parameters, the different variables such as the buccal lingual contour change, the soft tissue thickness and the tissue discoloration, which are incorporated in the anterior aesthetic area. And we should ask ourselves whether or not it is important to place a provisional restoration to mechanically support the soft tissue, and if it is important to place a bone graft, a connective tissue graft, or a combination of those at the moment of the implant placement in order to manage that gap. So in two single words, we should think always in a biological way.
Yes, when an implant is placed in anterior type 1 socket, there is always a gap, a jumping distance to manage. Literature tells us that bone remodeling always occurs in the first healing phases, altering the buccal lingual dimension. The question now is, it is important to place a bone graft, a connective tissue graft, or both, Andrea?
And we should ask ourselves if this is important to place it under a in order to increase the survival rates, in order to increase the osseointegration rates, or only maybe to increase the aesthetic the aesthetic outcome of our final restoration? Let's talk, for example, about survivals. If we look at the literature, these are two pictures which basically is the most common scenario in the immediate implants. So we have the implant placed slightly palatal, and so we have that gap that Alessandro was mentioning before. These articles, which were published in the early 2000s and the late 90s, basically they were only evaluating the survival rates in their studies, and they were not placing anything in the gap, neither bone graft or connective tissue graft. They were only placing immediately the provisional restoration. And if you look at the survival rates ratios, they had on average 97% of survival rate, which is a great number, a huge number. And all of them were basically mentioning that in order to obtain a survived implant, the key factor to achieve was primary stability. So how can we achieve primary stability? Of course, the surgical technique, but also the implant design and the surfaces are playing a key roles, but also managing in a biological way that specific site, such as the extraction site, is of extreme importance, because we should know the blood supply of the socket, which is given by the periodontal ligament, the endosteum and the periosteum, and we should treat it accordingly without opening any flaps, without damaging the buccal plate, in order to not to eliminate, if we open any flap, if we open a flap, not to eliminate the third blood supply of the socket, which is the periodontal ligament, which is the periosteum, because remember that when we extract the tooth, we remove as well the periodontal ligament, and in the anterior aesthetic area, the endosteum is very thin and basically is not giving any blood supply to the area.
And we know that the bundle bond we lose after tooth extraction. Avoiding to elevate the flaps during the tooth extraction will permit to leave the periosteum in place, decreasing then the resorption rate of the extraction socket. This is very important. Remember, no flap, never in type 1 socket.
And this is what we were discussing. Ideal situation in type 1 is the left scenario, where we have a thick buccal plate with a thick gingival biotype. But what we were mentioning at the beginning, most of the time, unfortunately, we need to face thin buccal plate, thin gingival biotype, like for example these studies by Mariano Sanz in 2011 is explaining to us. And so we need also to understand why these authors that were publishing in the early 2000s were obtaining these buccolingual changes of 4 millimeters, 5.9 millimeters. So they were having a huge socket dimensional change.
How come a so huge number in the buccolingual changes?
Well, if you go and read in deep the article, in all the above articles, the authors, in order also to do these measurements, were opening the flaps to extract the teeth, and so that was the reason why they obtained these huge dimensional changes. So in order to give you the first take-home message of the day, remember that when you are facing an extraction in anterior aesthetic zone, never to open any flap.
And what about osseointegration? Managing the gap with bone graft or tissue graft will lead to an improved osseointegration.
Well, let's try to give an answer to this question. Here you see some cases in where you see different also size of gaps, and let's say that before this article, which is an histological proof of principle given by Dennis Turner and Stephen Chu 2011, there was a discussion that maybe depends on the size of the gap, but probably this was not the case.
Yes, in fact, despite a large gap distance, 4.2 millimeters, it is possible to achieve osseointegration without placing anything in the gap. And this is another important consideration to keep in mind.
And so let's have a look, and we went back to see and consider some of the publication that we did in 2010. This was a case. This is a case that was taken by a case series that was published, and here you see two contralateral canines in where we had a type 1 socket with thick biotype. Of course, we evaluated also all the diagnostic approaches: gingival level, interdental bone height, presence or not of the buccal plate, and distance from the alveolar crest, and we treated these cases without placing anything in the gap.
Yes, so once again, this approach involves automatic tooth removal without flap elevation to maintain the remaining blood supply from the periosteum and the endosteum from a maximum healing potential, since the periodontal ligament is the third blood supply that is eliminated during tooth removal.
And here we have the final case. As Alessandro mentioned, we wanted to show you what? The bucco-palatal contour changes. And here we are only showing you the frontal picture, in where everything seems perfect. We see a pink and white balance, which is perfect. We have the, let's say, the
good symmetry, no, of the gingival margin.
The mimicking of the tooth with the natural adjacent dentation. So everything looks nice, and also looks nice at the X-rays control. But probably mid-facial recession, which was the parameters that we were evaluating in that article in 2010, is yes an important aesthetic parameter, but is not the only relevant one, because
obviously, if you have a good thickness of soft tissue to manage.
Yes, that can be managed effectively, also playing with the abutment crown contour. But look, for example, at this frontal picture at 9 years follow-up. Look, or 10 years follow-up already. Look at the root profile of these two canines. Especially look at the root profile on number 23. We had like a shrinkage.
Yes, but not 4.9 millimeter.
Of course, because we didn't open any flap, so we were as minimal invasive as possible. We maintained the blood supply, but nothing was placed in the gap in order maybe to support the overall contour, the overall volume. So maybe we should ask ourselves that if we would have placed something such as bone graft or maybe a connective tissue graft or a combination of that in that area, we probably would have enhanced the aesthetic on a long term.
The dual zone article has been probably the turning point on this topic, introducing a completely new way of thinking, but also evaluating the most important parameters, such as the buccal palatal contour change, the peri-implant soft tissue thickness, and the gingival tissue discoloration.
And the measurements that were done were based on the contralateral side, were based on digital calipers measured on study models, and we will see also a new way of, thanks to the digital solution, of recording this data in a statistically significant way.
And the study concluded that by combining a bone graft together with a provisional restoration, the authors, on average, maintained unaltered the initial situation.
And let's have a look to another case that was done in our clinic. Here you see the diagnostic approach, which is always important, defining which kind of anatomical scenario, type 1 socket, and which kind of gingival biotype we are in, thick biotype. You see that the extraction was performed without elevating any flap, and then we were ready. After that, we double check if the buccal plate was still in place after the extraction to place properly the implant in the 3-dimension of the socket.
We do a zone bone graft the gap, and while doing that, we use a flat contoured healing abutment.
And dual zone bone graft the gap means to place the bone graft up to the gingival margin, helping yourself with what? With the tall?
Yes, with the tall and narrow enough
healing abutment
to allow the bone graft to be placed and packed against it with a dedicated instrument to the most coronal aspect of the gingival margin, as Andrea said.
And then we can also incorporate, also in this case, new working tools. So you see the digital dentistry is really a great tool that can be incorporated in our treatment plan, but the sequence is always given, the sequence of the corrective therapy is always given by the traditional background that each of us has, and we can finalize this case in one single shot by taking the impression the same day, the digital impression, the same day of the implant placement. We can finalize the case really in one single shot. We can also have the provisional restoration done in a digital way utilizing PMMA, for example. PMMA, which has then to be bonded together with the T-bases, and we have different kind of T-bases. T-bases which they have like can be gold plate, in this case it's also pink, and we can call it a sort of screw mountable crown that can be done a full contour ceramic restoration, zirconia or lithium disilicate, in this case is PMMA, and then we will have zirconia at the end, and the crown is basically cemented to the smart bait outside the mouth but is screwed into the implants. And look, 4 months later, this is the occlusal view.
Yes, the occlusal view at 4 months follow-up, notice the increased thickness and the stability of the soft tissue.
Most of the time, the bone graft gets encapsulated into the supra-implant soft tissue, giving then more strength to the tissue itself. And then we can finalize the case. We already have the record of the impression, so we can send everything to our lab, and our lab can finalize and do the final characterization on top of the monolithic zirconia crown. Screw mountable crown once again. Here you see the different parts and pieces that are then bonded together, and this at 4 months later is the final case.
And if the corrective therapy has been done very well, properly, okay, you can obtain this kind of restoration in 2-3 appointments, no more.
So optimizing also the overall managing of your dental clinic.
To sum up this first part, we can state that the bone graft acts as a scaffold that stabilizes the blood clot, while the provisional prosthetically seals the socket and mechanically supports the soft tissue.
And the question that might arise is,
which kind of bone graft should we prefer?
And on this there is still an ongoing discussion in the literature, and there is no basically evidence base. What we can say is that from our clinical observation, it seems that if you place in the gap between the implant and the bone, so it means in the bone zone, it's preferable to pack slow resorbable bone graft till the bone margin and fast resorbable bone graft in the tissue zone above to the level of the gingival margin. This combination seems to be the most effective to be placed in the gap. But as I said, it's only clinical observation and we need to do more studies on this.
But let's see now what other clinical alternatives do we have to treat this kind of patient.
So we saw the dual zone bone graft. What do we have again? What do we have more?
Yes, the partial extraction therapy technique, which derives from the socket sheet approach introduced by the Hurfeller group, entails retaining the buccal aspect of the root simultaneous to immediate implant placement.
Of course, each technique that we are discussing has its specific guidelines and its specific protocols, but none of them, all of them need to have a diagnostic approach of the case, like we did once again for this specific case. You see, high aesthetic risk profile, we define which kind of anatomical scenario we are in, type 1, which kind of gingival biotype we were in, thin biotype, and then we started thinking which technique to apply.
Yes, as Andrea just mentioned, the clinician must carefully examine the patient's risk profile before the treatment plan is established, and this must be done prior to tooth extraction. Beside medical risk factors and habits such as smoking, the local anatomy is most important for the selection of the treatment option. Thus, a 3D CBCT is most often used to assess the details of the local anatomy.
And by looking at this CBCT evaluation, we can also decide which kind of techniques to apply, because look at the buccal plate here. It's very complicated to extract this tooth without damaging the buccal plate. It's not impossible, but it's very complicated. And so why not to apply the partial extraction therapy technique in this specific case, so we can retain that piece of root in the buccal aspect which will help us in maintaining the buccal palatal contour volume, and we will avoid as well to damage the buccal plate. You see, each technique has its benefits and limitations, but also its guidelines, and so it's very important to have all these techniques in your clinical armamentarium to choose the best technique that fit properly in that specific patient. Sorry, I went back. Let me go forward. Also here we can incorporate the new digital possibilities by simply digital impression in the initial situation in order to create a provisional restoration shell at the lab. And also you see that lab technician that right now is combining the digital camera's pictures with the digital impression STL files in order to optimize the aesthetic of this provisional restoration. And at this point we are ready to start the surgical procedure of the partial extraction therapy.
During the surgery, the root was sectioned in a mesiodistal direction along its long axis, as far apical as was possible, using a long shank root section bar, and the palatal piece root with the apex, obviously, was carefully removed.
Of course, the protocols, step-by-step protocols, are of extreme importance in each technique you are applying, and here you have some of the articles that were recently published by Howard Glackman and Maurice Salama on this specific technique.
The remaining buccal root section was then reduced coronally to 1 millimeter above the alveolar crest and thinned slightly to a concave contour. A malposition of the implants must be avoided by all means, since this is a common mistake with immediate implant procedures and presents risks for a complete failure of the treatment. A provisional crown was then constructed chairside with an emergence profile to support the coronal tissues while ensuring adequate space between the shield and the provisional.
And here in the picture you can appreciate this S shape of the provisional restoration, which is made on purpose for this specific technique in order to enable the connective tissue graft to adapt properly around the provisional restoration.
To cover the shield during the healing phase.
At this point we are ready to do what? To place the bone graft that will also always help us to support the buccopalatal contour, and on top of it we will screw down the provisional restoration, removing the excesses of the bone graft which will be then squeezed out by the provisionals. And here the same day of the extraction is the same day when the patient is walking out from our clinic with their tooth and without having anything removable. So remember, comfort of the patient also during the treatment from phases, and what we said at the beginning, these approaches, this immediate implant placement in the aesthetic zone with immediate provisionalization, what they are able for us, they are able to preserve the soft tissue around, the hard tissue are preserved by the technique that we are choosing. Look at the root profile that we were able to obtain and to maintain in this type 1 case. Type 1, the target, our goal, the objective of the therapy is to preserve what we have. and that was the goal that was fulfilled also in this case.
Anyhow, the socket sheet and Pontic sheet are still in their clinical infancy and require long-term clinical data before they can be proposed as a routine in everyday implant dentistry. But this article, just published by Howard Lachman, Maurice Salama, and
Jonathan Dutoit, which is a fellow of Howard Lachman in Cape Town,
is providing some data at this regard.
So you see that little by little each technique is getting its number, and we need to have long-term data and also statistically significant volume measurement. And how can we do that? Digital impression once again is giving another tool, because look how we can standardize this measurement thanks with the intraoral scanners and the CAD software dedicated to this.
If you have obviously a digital tool consistent. In the dual zone article, the authors also stated that many factors can influence the final aesthetic outcome, including the periodontal phenotype that might require an additional surgical intervention.
An additional surgical intervention that can be done before, during, or after the implant placement. But before discussing when to do the additional surgical intervention, we should know how to define which kind of gingival biotype we are in, and we have different opportunities, such as, for example, the CAN gauge that was published, but also the Rasperini and Tiziano Testori gauge, in order to get like this probe visibility, which is associated with the thinner gingival tissue and bone. And we see also different approaches. For example, we just discussed about the partial extraction therapies, we discussed about the dual zone approach. Each of these situations has benefits and limitations. But let's see how can we utilize the connective tissue graft, not only, as we saw at the beginning, to manage a complication, but to avoid a complication.
CAN also described the biotype conversion around both natural teeth and implants following the CT or connective tissue graft procedure.
So connective tissue graft seems to be very effective, because look at these articles.
Yes, and the combination of immediate implant placement and provisionalization and connective tissue graft resulted in a sufficient per-implant tissue thickness to hide to underline the underlying restorative materials.
And we have extremely important results if we compare when we place a connective tissue graft and when we don't place a connective tissue graft. Another article which is very interesting was the one published by Grunder, always back in 2011, in where he was evaluating in two groups, the test and control, the volume loss and the volume gain. So you see, now we are discussing about volume, we are not discussing about mid-facial recession. And in the group in where he was placing the connective tissue graft, he had a volume gain of 0.3 millimeters, while when he didn't place the connective tissue graft, he had a volume loss of 1 millimeter. So connective tissue graft seems to be very effective if we look around in the literature by different authors, and that was one of the reasons, because together with Team Atlanta, together with Maurice and Henry Salama, we decided to create this protocol, which we called surgical veneer grafting procedure, which basically is a combination of a dual zone bone graft and a connective tissue graft management, which has to be done in a specific way, which we'll discuss in a second.
The goal is to limit the buccal contour change after the extraction and potentially enhance the thickness of the peri-implant soft tissue coronal to the implant abutting interface.
So as each technique that we discussed, also the surgical veneer grafting has a specific protocol, a standardized protocol that must to be followed step by step, and this is what we're going to do while presenting this case.
Yes, look this patient with an high smile line, with a failing left central incisor due to a palatal fracture, who complained about pain and mobility of number 9 and diastema, who wanted to preserve. Notice the gingival asymmetry between the left and the right side of the patient mouth.
So, type 1 socket as clinical anatomical scenario, thin gingival biotype when we discuss about the gingival phenotype. Surgical veneer grafting maybe mainly has 5 different steps. The first step is what? The extraction.
Yes.
The extraction must be performed in the most or in the less traumatic way by utilizing specific instruments such as dedicated periotomes in order to cut the fibers around the root in this case, and small forced tips in order to enter in the sulcus, manage to take the root and perform rotational and out movement, not mesiodistally or baccopalatally, because we want to preserve what? The anatomical scenario we are in, which is type 1.
Yes, after the extraction, we must double check the bone crest respect to gingival margin before placing the implant.
And after that we double check everything, step number 2, implant placement. Implant placement that has to be done properly in the 3 dimension of the socket that we are in. So not only discussing about baccopalatally, that we know that we need to place the implant slightly palatal, but also mesiodistal and also apicocorona. The implant must be placed 3 to 4 millimeter up to the gingival margin in order to give the adequate running room for the provisional restoration emergence profile.
So the implant must be guided always by
the prosthesis.
Yes.
Okay. And now we see that we place our implant, we have this gap to manage. Let's see how we manage this gap with the surgical veneer graft.
Yes, and once again we should ask ourselves which one in this specific case is the best way to manage this gap, preventing a buccal palatal collapse of the post-extractive bridge.
First thing to do is not packing anything in the gap, but
fabricate first an accurate provisional restoration.
And how can we fabricate this provisional restoration? How should we fabricate this provisional restoration?
Yes, 2 different zones within the implant abutment and crown are defined as critical and supercritical. Any alteration of these 2 areas can modify the soft tissue profile, including the gingival margin level, papilla height, gingival architecture, labial alveolar profile, and gingival color.
And as you can see here, the implant placement, the proper implant placement is key in order to create this smooth emergence profile with subcritical and critical contour. We need to get this adequate running room, and also we should do what?
Smoothing and steam cleaning the provisional restoration will improve the soft tissue response and the epithelium attachment.
Fourth step now is the critical step of the surgical veneer grafting, which is what? The connective tissue graft management. In order to specifically do this technique, we created together with Omni a dedicated surgical kit, which is the SVG kit, or the SVG kit, which is going to be officially presented at the next Dentally Speak Global Symposium in Miami. We are very happy to see that we basically have the hands-on that we are doing the Thursday before the general session, which is almost sold out, and so we are hoping to see many of you in Miami to show you in person this kit. And how can we utilize this kit with these specific blades?
As described by Professor Zucchelli, an epithelial connective tissue is harvested using a 15C blade or a minimal spoon blade, 2 millimeters apically the palatal gingival margin of the second bicuspid and the first molar. Note that the first incision is horizontal, then the 2 verticals, and before the last horizontal incision, I prepare the graft, avoiding in this way to get too much bleeding in the surgical area and leaving the submucosa to protect the bone.
So, which are the key words for this phase? We need to create, first of all, a partial thickness envelope in the recipient site. In this partial thickness envelope, the graft, which is a white, thick and dense connective tissue graft, is then sutured with 3 stitches, one mesial, one buccal, one distal, and where it is placed, this graft, and which are the dimensions of this graft, Alessandro?
Yes, the graft usually has to be 1 millimeter thick, 1 millimeter thick, long 10 and wide 6 millimeter. The epithelial and fatty tissue is removed to side, while on the recipient side is created a partial thickness envelope, as Andrea said, in where the graft is sutured to stabilize it with three stitches.
And here you see how deep this partial thickness envelope must be. 3 millimeters in the tissue zone, but also 3 millimeters in the bone zone, because we want to get blood supply for our graft not only by the internal part of the flap, but also by the periosteum, which is in the bone zone area. And on top, and then you can see here then the connective tissue graft before being packed and sutured is deepithelialized chair side. So we are removing all the yellowish fatty glandular tissue.
Fifth and final stage is the dual zone bone graft utilizing a flat contour healing abutment.
We already said that this must be tall and narrow enough because what this gives us the opportunity.
Yeah, to allow the bone graft to be placed and packed against it with a dedicated instrument to the most common aspect of the gingival margin.
So you see, this is a combination of a surgical and prosthetic protocol that, if it is done properly, can allow us to look the soft tissue integration, like in this patient at 3 months, and this is the white and pink balance that we want to achieve.
Yes, look at the integration after 3 months, look at the root profile.
This is exactly what we want to achieve, because at this stage, when we first exclude the provisional restoration,
notice the height and the thickness of the soft tissue.
And this is given not only by the implant placement, by the connective tissue graft and by the bone graft, but also by what? By the properly management of the provisional restoration, of the emergence profile of the provisional restoration, the critical and the subcritical contour. And at this point, we are now ready to do what? To incorporate new digital working tools, such as the intraoral scanner, to copy and paste the clinical situation. This is the this is the anteprima, the preview that we have in our intraoral scanner, and this is what we can do, copying the provisional restoration emergence profile.
Yes, this is another
way of doing it
to duplicate the emergence profile of our provisional restoration. In fact, we know that the acrylic resin does not shrink, and thanks to the optical scanners we can record the provisional restoration emergence profile.
But this concept is deriving once again from the traditional background, because also in the tradition we were able to customize the impression copying and get this information to our lab. The only thing that we needed to do 9 passages, which were time consuming, and probably, since we have different materials, less accurate than a single passage like we can do with the digital impression. Here you see it's very easy, it takes really 30 seconds to do this. And after that, everything is sent digitally to our lab, which can start working at the CAD.
In fact, starting from the provisional restoration shape, the dental technician can design his digital project. Note the correct position of the screw hole axis that plays an important role in this case because we prefer the screw retained final prosthesis. A model produced with the digital workflow provides the required position for the ferspatic ceramic layering.
Also, the materials in where the model is produced is another variable. In this case was produced with nylon P6, created thanks to laser sintering with specific characteristics. But once again, you see that we know and we have several details carried in each passage that we're doing. At the end, we can finalize then the case.
Yes, look at the CBCT evaluation, look at X-ray evaluation. Despite the bone remodeling, we maintain the great volume, the great heart tissue volume.
And look also that we maintain the diastema because the patient wanted to maintain her diastema, but what is more important is the before and after picture, which is our goal in type 1 clinical anatomical scenario, to maintain what we have. And look this picture, before and after, where if I put this in higher magnification, you probably are able to appreciate better the root profile of number 21 or number 9.
Yes, the connective tissue graft shape is visible, but the interesting aspect is what we have seen down the road.
Yes, and take attention on this specific moment, because this is what changed our way at 3 years. This is what changed our vision. You see, time 0, look at 3 years. Look, if I do a higher magnification of 3 years, what you're seeing? You're seeing basically creeping on this connective tissue graft, which is keeping maturing. Okay, and the question is this only one case?
Yes, and look how it has been possible to mimic the root profile shape from this perspective. What should we ask ourselves now is if the surgical veneer grafting protocol is predictable.
Yes, because we only showed you one case, and we only showed you this follow-ups with this connective tissue graft creeping down the road in one single case. But let's have a look in many different cases.
After an appropriate diagnostic approach, the goal is always to maintain stable the bone volume and architecture and preserve the soft tissue control.
But look at the root profile of this number 9 that was extracted, and here you can see also some bone chips particles which are still there, and that we digitally copied once again with our intraoral scanner, and this case was finalized by Dr. Davide Cortellini and the dental technician Angelo Canale, both active members of the Italian Academy of Pros, and they managed prosthetically perfectly this case. You can see once again the aesthetic risk profile, the transition zone that this patient was exposing, but you can see that the mid-facial recession is yes important, but is not the only one. Remember, the root profile picture that we showed you before is probably the aesthetic picture of this case.
Also, in slightly different clinical situations such as this canine, the surgical veneer grafting protocol, in our opinion, is a reliable approach that could be used in thin periodontal gingival phenotype to avoid the collapse of the buccal lingual contour despite the bone remodeling. Look, this huge gap.
Yes.
In this case.
And look the root profile of this same gap without the tooth, but with only the implant, and look the root profile in the picture in the right side. It's very impressive, this picture. Look the before and after, look the CBCTs, but what is even more impressive, look at the follow-ups. This is the time 0 when we deliver first the crown. Look at the small recession that we have on number 24. Look at 4 years.
Yes, look what happened at 4 years. If you have a strict protocol, surgical and prosthetic protocol to treat this kind of patient, you can obtain this quality of the result.
Look the creeping of the soft tissue, which is keeping maturating, is keeping growing, and so is giving more predictability, is protecting, is mimicking what we have below, which are the prosthetic components, which is the key of our therapies. And so this protocol seems to be very effective also in patients very complicated like the next one that we are presented.
Yes, let's analyze also this high smile line patient who presented with a post-orthodontic broken splint in the anterior area. The orthodontic treatment took 5 years. She was worried for the anterior teeth increased mobility and diastemas, and no parafunction were detected in this case.
And in this kind of complicated case, the communication with the patient is key. And once again, we have tools, digital tools that can be incorporated in our treatment plan sequence. and such as the digital smile design, we can teach, we can lecture to the patient, explaining and making her aware of all the possible complications, of all the aesthetic issues that she has, in order to let her understand that we are doing the best as possible for her, and to have also her compliance. In this case, we extract number 11 and 12, and we needed to maintain that huge space, that huge buccopalatal dimension that you will see in a different picture in a while.
Yes, in one single session, and remember, in one single session, the data proportion were improved. No removable solution was given to the patient, and a mini-invasive surgical treatment was performed. After the implant integration, it has been prepared the veneer based on the ESD mockup. This permitted to be more conservative on the tooth structure. If we preserve the animal, we will have a better adhesion and consequently an improved strength of the lithium disilicate veneer.
But besides all the surgical and prosthetic protocol, look the buccopalatal volume that we needed to maintain. We were in a type 1 sockets. Also here, we need to maintain that huge buccopalatal volume, and we have that papilla between central and lateral. Remember, we are in the most challenging scenario in the anterior area. Look the buccal picture. Look this. Look, you can see, you can appreciate where the connective tissue graft has been placed, but also look here. Look the papilla in between.
Yes, the proper implant position, together with a combination of bone and connective tissue graft, will permit to maintain the root profile and especially the interdental, the interimplant or interdental or interimplant papilla of this very challenging case.
And at this point, of course, we can incorporate once again what? We can incorporate new working tools such as digital impression to copy and replicate what we have clinical. We already said that we will incorporate number 21 and number 13 to manage prosthetically the huge prosthetic space, and we needed to do what? We needed to create a model.
Yes, then the dental technician workflow moves on, starting from the base of the provisional restoration, shaping his digital project and producing then a model in a completely digital environment.
Utilizing two different materials in this case, we will have like two lithium disilicate veneers and a zirconia framework on top of which is going to be layered ceramic for the final aesthetic in the implant restoration. And look these final images. You see that the blueprint of the digital smile design was maintained and was reproduced in the final restoration. Look at the smile of the patient, diastema is closed, and this is the final restoration in place.
Yes, here is the final restoration in place. Note the perfect adaptation between the crowns and the soft tissue. Look on the right side the additional veneer on 13 and the implant and ponting restoration, which are mimicking the natural aspect. We can recreate, we were able to recreate a great proportion in the front area.
Look the before and after. It's very impressive, the before and after of the dentiofacial analysis, but what is also impressive is the aesthetic risk profile of the patient, how much she was showing. Okay, and another impressive thing is what is happening down the road at 3 years. Look the connective tissue graft here.
Look how much mature the connective tissue graft. It is very important to pack it into the envelope a 1 millimeter of great quality of the connective tissue graft, Andrea.
Yes, that is why surgical veneer grafting is like partial extraction therapy, like dual zone, a standardized procedure that must be done step by step, and especially the connective tissue graft has a crucial role and must be done with a wide, thick and dense connective tissue graft.
We have been collecting data over the last 4 years, and the numbers we are obtaining are pretty interesting.
Yes, these are some of the numbers that we collected that are still unpublished, but you see that once again, diagnostic approach, but also standardized protocol, so immediate implant, provisional restoration, connective tissue graft, dual zone bone graft in type 1 socket with thin gingival biotype, so means standardization. And here you see another case, another central incisor, diagnostic approach with the CBCT analysis, flapless extraction, implant placement in the 3 dimension of the socket, provisional restoration management, connective tissue graft management, dual zone bone graft, and here you see the control at 3 months, and here we have some of the unpublished data that we are looking over and over. And we tried to divide, like it was done in the dual zone article, on tissue zone and bone zone, and what we noticed, and we were positively surprised, is that in the tissue zone, which is exactly where the connective tissue graft is mainly placed, we had an augmentation, an improvement of the volume of 0.6 millimeter, 0.6.8. Of course, we are still we are still analyzing those data, we are still double checking those data with our digital tools, combining also the data that are coming from Team Atlanta, because at the end of the story, what is that our patient wants from us, Alessandro? What they need, what they look from us?
Predictability.
They want predictability, and predictability is given by the presence of the hard bone, the soft tissue on top, and the harmony that these two components are giving with the final prosthetic restoration.
However, mid to long-term studies with a minimum of 5 years of follow-up are needed to judge the aesthetic long-term stability of this interesting approach. And the intraoral scanning technology will be important for digital standardized measurements.
Exactly, and here you see some of the measurements that we are doing on the right side. But let's conclude this webinar with some take-home message. First of all, immediate implant placement procedures should be used with caution, in the sense that we need to understand if there is or there is not a facial bone wall. The presence of the buccal plate is critical, and also we should define which kind of gingival biotype we are in.
And stressing the concept once again, remember that in anterior maxilla the aesthetic outcome and its long-term aesthetic stability is of paramount importance.
We should select carefully each case, we should know which kind of techniques we have in our clinical armamentarium, and we should tailor each technique to the specific needs of that patient.
Let's then conclude with some guidelines based on our clinical experience and observations of that.
And so, since we discuss mainly about type 1 socket, we like to define the type 1 socket and to divide the type 1 socket in thick and thin biotype, in where we have a thick and thin buccal plate, which has always to be intact. And in the thick biotype, we think that the dual zone bone graft management is a great way to manage this situation, and if everything is done properly and standardized, you can expect the optimal result. Whether when we have a type 1 with the type 1 socket with thin biotype, we think that surgical veneer grafting and partial extraction therapy are today the way to go. For example, we didn't discuss about ankylosed tooth, for example, but when we have an ankylosed tooth, probably the partial extraction therapy is the way to go.
Yeah, absolutely.
So you see, anytime you need to know benefits and limitations and trying to tailor the technique that are available to your specific patient.
Yes, and I want to thank to all our team, and thank you very much of all of you.
See you in Miami in 2 months.
Yes.
Have a great day.
See you in Miami in 2 months.